Hello, this is Dr. Daniel Kelly from Pacific Neuroscience Institute. I'm going to speak to you today on value-oriented architecture for brain tumors in the Providence, Southern California system and provide a preliminary analysis. I want to thank my colleagues, Dr. Garni Barkadarian, Amanda Rodriguez, Regine Malari, and Dr. Neil Martin. I also want to thank Tim Smith for inviting me to participate in your symposium. These are my disclosures, and we're coming from Santa Monica, California. So what is value-oriented architecture? This is a term coined by Drs. Khalib Stow and Ari Robasek, who are in the Providence system, looking at this very large healthcare system that we have with over 24,000 physicians across 7 states, and looking specifically at cost and outcomes and trying to drill down into the specific practices that drive variation. And they refer to that as value-oriented architecture. And in this article that was in the New England Journal a few years ago, they look at the cost breakdown and how they achieve these cost analyses through the EPIC system. And then they look at an outcome score, which looks at a number of different areas, including complications, length of stay, and of course, cost. And this is an example for total knee arthroplasty. And you can see some trend there of volume versus outcomes, and this is a theme that we'll look at in considerable detail in this talk. So when we talk about brain tumors, I think it's very helpful to understand sort of the epidemiology, the demographics of brain tumors, and no better source than the Central Brain Tumor Registry of the United States, which comes out every few years with a very detailed analysis of almost all the brain tumors, primary brain tumors that are operating in the United States. And you can see here from this chart that almost 70% are non-malignant tumors, predominantly made up of meningiomas and pituitary tumors. And then there's a large group of malignant tumors, including the gliomas, for about almost a third of all the primary brain tumors. And this breakdown goes even further state by state. And so we can see that in the state of California, it's estimated that there will be an estimated 10,000 primary brain tumors cared for in the year 2020. And that would include almost 5,000 skull-based tumors. And you can see the breakdown there. If we look at the brain tumor centers, or quote, centers of excellence, self-proclaimed centers of excellence across California, you can see that there's at least a dozen of those. And if you just do some simple math, you would, even if each of these centers did over 400 brain tumors a year, that would leave at least 5,000 brain tumors that are probably going to other centers, potentially low volume surgeons and centers. And I think that's an important issue that we will keep coming back to. So what is a center of excellence? Well, this term is used a lot. We published a paper about this in 2012 on pituitary centers of excellence, indicating that this is really a team of people that promote collaboration and use best practices around a focus area to optimize outcomes. There are excellent examples across medicine, as we know, comprehensive stroke centers, trauma centers, and bariatric surgery centers of excellence. So this is a concept often loosely applied, but it is something that I think has some merit. At Pacific Neuroscience Institute, we have a large multidisciplinary medical group of almost 40 doctors. And our brain tumor faculty, which I would include pituitary, skull base, and interaxial brain tumors, includes about 13 faculty really focused on brain tumor work. And this does not include our radiation oncologists and some other specialists. So we are trying to practice this as well. And there's quite a bit of data out there on the impact of centers that perform, centers and surgeons that perform a lot of surgery compared to lower volumes surgeons and centers. This is from the state of New York, an analysis, over 10,000 brain tumors over 10 years. And they high cumulative and high annual volume surgeons had shorter length of stay, fewer complications and reoperations, and lower costs. So this theme of volume and experience with better outcomes is shown. This is a paper that came out in 2003 by Brooks Swearingen and his group in Boston, looking at transsphenoidal outcomes, doing a nationwide sample, and again, showing both by surgeon and by hospital better outcomes at the higher volume centers. And then another paper looking at metastatic brain tumors across the country, a large data set, and again, higher volume hospitals and surgeons provided superior short-term outcomes. And this data goes across medicine, it seems across surgery, and it led to an editorial pledging to eliminate low-volume surgery in the New England Journal 5 years ago, made by the systems Dartmouth Hitchcock Medical Center, Johns Hopkins, and University of Michigan. So let's go to our system, Providence, Southern California, which includes 9 different hospitals. And you can see here just the aggregate volume of brain tumor surgeries for the 2019 year, and you can see a large variation. Our Pacific Neuroscience Institute has been predominantly at Providence St. John's Health Center, but we also now cover a little company of Mary that in Torrance. So we really are covering since 2017 two hospitals. And here's just overall brain tumor volumes for these main tumor types. And again, this is data that we collected through this VOA process, through the EPIC record, and we decided to look really just at the large, most common tumor types, and we included metastatic tumors in that group. And you can see that Providence St. John's Health Center and Little Company account for about 45% of all of that volume. When we break it down by the different tumor types, again, you can see the breakdown, and the Pacific Neuroscience group here aggregate again, and here's some percentages showing that breakdown across meningiomas, pituitary tumors, malignant tumors, and other tumors. Looking at the data in a slightly different way to assess length of stay and the observed and expected readmission rates, you can see here, Little Company is this Torrance here, St. John's, and these blue bars are the volumes. And you can see a lot of variation across the system, across these different hospitals, Mission, Holy Cross, Burbank, St. Joseph's, and certainly some outliers in terms of long length of stay and readmissions. And so this data, I think the important thing is to see the variation across the system. And then when we look at this in a little bit different way, hospital case volume versus average length of stay. And again, we have our main hospital, Providence St. John's Health Center here, and you can see this relationship between length of stay and volume, and a pretty strong correlation that the higher volume centers tend to have a lower length of stay, at least for meningiomas and pituitary tumors, and some degree to malignant tumors. When we look at individual surgeons, and we took the 2 highest volume surgeons in the region, which happen to be in Pacific Neuroscience, we can see a significant difference here in length of stay, almost 2 days for meningiomas, 2.5 days for pituitary tumors, and again, about 2 days for the malignant tumors. Some of this may be driven by critical care usage. You can see here that for most of the centers, the brain tumor patients do use critical care for at least 1 or 2 days. You can see here at Providence St. John's, only 19%, and that's clearly driving some of the length of stay and the cost. And here's the cost data. And again, you can see the normalized cost across the whole system. Again, the 2 centers that we're mostly involved at, and again, a wide variation in cost, but certainly some of the lower volume centers have the highest costs. When we look at this again, broken down by tumor subtype a little more individually, again, for the meningiomas, pituitary tumors, there is a trend for the higher volume centers to have lower costs. Not so much with the malignant tumors, but certainly with meningiomas and pituitary tumors. And then again, if we look at this of high volume surgeons versus the remaining cohort, this plays out again in terms of significant cost differences, almost $2,000 difference per case for meningiomas, over $4,000 a case for pituitary tumors, and about $1,500 for malignant tumors. So there's certainly an opportunity here to improve things. When you look across Southern California neuroscience service lines, when we look at the brain tumor service line, here's just labeled brain, and inpatient utilization, you do see that this is a significant growth area, almost 20% over the time period from 2016 to 2018. So in summary, I think the Central Brain Tumor Registry of the United States data, specifically when we look at California and we look at the centers of excellence that we're aware of, it does confirm that most brain tumor patients are going to lower volume centers and surgeons, probably at least 50% of them. Our preliminary BOA analysis within the system in Southern California illustrates large variations in costs and outcomes between centers and surgeons. So there is an opportunity for improving brain tumor care and reducing costs by possible regionalization and aggregation of brain tumor services. But clearly such changes will not come easily for a variety of reasons, both with surgeons and centers themselves. This will be, I think, the biggest challenge. And clearly we need further, more detailed data analysis on individual surgeon centers and specific brain tumor subtypes to better understand the costs and additional opportunities to enhance cost-effective quality across the region. Thank you.